Hi friends, this is Dr. Kunal. I'm a MIST mentor. I have come with the FMG recall questions for the subject of pathology and some part of medicine which we have covered together in the classes. Now regarding the paper, we are having the review as though that first paper was a pretty easy, single liners were more doable. In the second paper, they twisted a bit. It was more a paper in which you have to apply your concepts and then you have to answer the questions. We hope that all of you must have did it in a way it should be, and we at MIST, we really hope and we pray to God that you come out with flying colors when the results are out. I'll start with the questions which have come in the exam. This is a proper and total recall based session in which after the interaction with a few of lovely students of mine, I was able to gather certain questions. So there might be some changes into the language or the options, but here it was not about regeneration of the exact question as to give you, but the essence of the question should remain the same. So I hope that you would find the questions to be as close as you saw in the exam, and if there is any change in the option, because sometimes if you have the other option, the answer for the particular question changes. So if you find something like that, so please comment in the comment section below, and that would help us in improving, and obviously your juniors, your coming batches, to get at the proper idea as to what came in the exam. So let's start with the session. The first question which came was, a 50-year-old female came to the OPD with headache. She was afebrile. Findings reveals the tumor measuring 2 into 2 centimeters attached with the dura mater. Finding in this patient will be consistent with. So they have given this two very important signs or two very important things here. One is that the patient is afebrile. So infection का history नहीं है यहाँ पे, and they have mentioned that there is some mass. Whether they have written tumor or they have written a mass, I'm not pretty sure about. Somebody said the mass was there, somebody said the tumor was there, but they have mentioned that it is 2 into 2 centimeters attached with the dura mater. So because it is, and the options which they gave was, one is meningitis, so it ruled out because it is, the female was afebrile, and we have done this in particular in the classes. This is a screenshot of the pathology workbook which we have, in which we have discussed that meningioma, they arise from the arachnoid capsule, the meninges of the brain, and in that we have discussed that the microscopic finding of that particular tumor are these psammoma bodies, which are the concentric deposit, the calcium deposit which we are seeing. And we have also discussed this in the cell injury chapter, where we discussed the dystrophic calcification, that this meningioma has these concentric deposits which are called as psammoma bodies. So this question has come from the topic of meningioma, and the correct answer for this question would be B, the concentric deposits. The second question which came was this: a 44-year-old female suffers from wheezing, cough every year at a same period of time. So this is some hypersensitivity which is happening in the person at a particular weather. Then they have asked degranulation of which cells will be responsible for these type of findings. So when we read this, we have discussed multiple times in the classes that this is all about type 1 hypersensitivity, where you are having this allergic reactions. So they have asked the degranulation of which cells. They have not asked that what is causing it. Like, we know that in type 1 hypersensitivity, the antibody responsible is IgE. We have done, again, a screenshot from the pathology workbook, that we have in type 1 hypersensitivity, we discussed that, because of the allergen, the Th2 cells will be, they would be activated, and then they would be secreting the interleukins which they secrete, and eventually the B cells would be increasing in number, and they are going to form the IgE antibody, because the antibody responsible for any allergic kind of reactivity would be IgE antibody. So IgE antibody is getting activated, then it attaches to the mast cell, the Fc receptors on the mast cells. Now these are your mast cells, and these mast cells, they contain the mediator that is called as histamine, and once this exposure occurs again the second time, there would be degranulation of histamine. But they have not asked that what will be degranulated. They have asked that this degranulation occurs from which cells? So degranulation of which cells is responsible for these kind of findings, these allergic reaction? So the answer would be mast cell. So the correct answer for this question is mast cell. Then question number 3, nitrous oxide, which is a very potent vasodilator, is formed from which of the following? Again, when I was teaching you in the classes the inflammatory mediators in the chapter of inflammation, again a screenshot from the workbook, we have discussed that L-arginine is responsible for formation of nitrous oxide, which actually is a very potent vasodilator, which also helps in production of nitrous oxide, peroxynitrite, and it also helps in platelet anti-aggregation. And I told you there that this is a repeat question. It has been asked few times in your exam prior that nitrous oxide is formed of which amino acid. So this is your L-arginine. So again, this is a straight question from the workbook. Arginine is the answer. Then the another question which came was macrophages are inflammatory cells which are responsible for killing pathogen in any kind of chronic inflammation. In liver, what will be the cell responsible for this function? So they have already mentioned that they're talking about a macrophage. They have already mentioned that they're talking about, they're asking inside the liver. So when I was teaching you cells of chronic inflammation, again in the classes, we discussed this, and I have given you the entire lines, as to which cells are present where. So in liver, we have discussed that, they are Kupffer cells. Sinus histiocytes, they are in the spleen. Mesangial cells, they are in the kidney. Ito cells, they are again in the liver, but they are fibroblasts. So they are helping in collagen deposition, not exactly they are not fighting in the chronic inflammation against the pathogen. So again, the answer for this question is very simple, Kupffer cells. Fifth question, rheumatoid arthritis occurs due to which of the following? In this, the options, as has been told, were like this. Type 1 and type 2 hypersensitivity were given together. Then it was autoimmune response, inflammatory response, and type 4 hypersensitivity. When we were discussing rheumatoid arthritis, I told you that rheumatoid arthritis, it's an autoimmune disease. Again, a screenshot directly from your workbook. This is an autoimmune disease, type 3 hypersensitivity happens. So again, a very straight question which came from the class notes, and the correct answer for this question would be an autoimmune response. Then an adult male suffers from road traffic accident, grafting was done using his own tissue. People said that, image was somewhat a little different, but exactly they were telling this, and image does not matter actually at this area because they are saying that the grafting was done using his own tissue. So when we were discussing this graft rejection topic in the chapter of immunity in the classes, the first thing I told you, types of graft. And in that, we all know, everyone knows this, that there are 4 kinds of graft: iso, auto, allo, and xeno. Iso means identical twins, auto means same individual, allo means same species, and xeno, when the grafting is done between 2 different species, like we are doing the valvular plasties. So that is xeno. So because they have said in the question that same tissue has been taken, same person, so agar same individual ke andar ho raha hai, to it is going to be an autograft. So very simple, the answer is autograft here. Then a child underwent ocular surgery for an eye tumor. They have not mentioned the eye tumor, but what they have mentioned is that enucleation is done. And enucleation, we know that, eye tumor mein retinoblastoma very common, or enucleation uske andar karte hain apan. What is the gene responsible for this tumor? So when we were discussing tumor suppressor genes, I was teaching you in the chapter of Neoplasia. There we discussed RB, this table we have discussed, and I gave you RB gene. The location also we discussed, and I told you it is seen with retinoblastoma, and even we discussed this, the role of this RB gene, because it is called as governor of cell cycle. So what is the role of this RB gene in the cell cycle? That also we have discussed, that Knudsen's hypothesis and all. So again, a very straight question came from the workbook. So RB gene is the answer for this question. Then question number 8, what is the type of inheritance seen in the image given below? Now, pedigrees we have done, even the 25 most important pathology questions which we discussed on YouTube. You people must have seen that. There also we have discussed 2 pedigrees, and in the classes, in the revisions, a lot of times all the mock contain pedigree analysis. So in this is the pedigree analysis which students have sent me, that this exact was given. And many of you were telling that it is dominant, but actually it is not dominant. For a dominant, this is again a screenshot from the workbook in which I explained you that whenever we are taking these kind of pedigrees, for any kind of pedigree analysis, the first thing you have to do is you have to see the options. So in the options, you have to understand that whether they are asking only Mendelian patterns or they have mentioned some non-Mendelian patterns as well. Now, out of the non-Mendelian patterns, I said in the class multiple times that you can only find out 2. and that is your, the gonadal mosaicism or the mitochondrial inheritance. If the non-Mendelian were not given and only Mendelians have been asked, then you have to see that first thing you have to decide is whether the pedigree is dominant or it is recessive. So as you can see in the options, what has been told to me is that only the Mendelian options were given. So things become a little simpler. And I have to first differentiate between the dominant and the recessive. How am I differentiating it? I will count the generations and I'll see that whether there is a skipping of generation present or not. So if I see on a first glance, I would see that, okay, there is some involvement in this generation, there is some involvement in this, and there is some involvement in this generation. So all the generations are being involved. So I may quickly go into, a conclusion that this is a dominant pedigree. So, but I told you, whenever you are deciding dominant and recessive, skipping of generation is the first thing you have to see. But the second thing is that whichever child is being affected, one of the parent of the child should always be affected. This is what you have to find out. Okay. So you see this particular here. These are the parents. Now, if it's a dominant pedigree, in dominant pedigree, if one of the parents is affected, they should definitely transfer the disease in the next generation. So these are the parents affected, but they are not, these are the child of these parents, these three. You are not seeing a disease inside. So this cannot be dominant. हो ही नहीं सकता ना बेटा. In this this is involved, but this has come from some other family. She does not belong to this family. So you cannot count it as that they have transferred it. No, they have not transferred it. They have not transferred the disease to their child. And dominant, it is not possible. So this becomes recessive straight away. This becomes recessive. Now, if it is recessive, the point is that after finding out dominant and recessive, you have to find out whether this is X-linked or autosomal. Now, if we are talking about an X-linked, I gave a very simple thing for X-linked. That X-linked mein beta, father only transmits the disease to daughter. Because father is what? XY. Father never transmits the X chromosome to the son. So if father only giving to daughters, and mother, if it's a dominant pedigree, mother can give to daughter and son both. If it's a recessive pedigree, then in X-linked, mother would make the daughter's carrier and make the son diseased. In this, I cannot comment on that whether father is only giving to daughters or not. So if I'm not sure about, I'll take it as autosomal, not X-linked. So the correct answer for this question would be autosomal recessive according to the pedigree sent to me by the student, that this is the pedigree which came. Okay, and we have discussed this thoroughly in the classes multiple times, and we have practiced also multiple times. So I hope this question also must be right for you people. Characteristic feature of hemolysis. Now, when we were discussing, the options were reticulocytopenia, decreased haptoglobin, neutropenia, all of the above. Now, when we were discussing in the class, okay, the first thing for the hemolytic anemia, we have discussed that, hemolysis means lysis of the RBC, and there are two kinds of hemolysis we have discussed, intravascular, extravascular, and I told you that haptoglobin is something which is very important to, count in the patients of hemolytic anemias. And whenever we are talking about anemias as such, in anemias also we have discussed that, anemia is decrease in the RBC count in the blood or decrease in the level of the hemoglobin inside the blood. So RBC count will be less inside the blood only for two reasons. One, either the bone marrow which is forming the RBCs, the bone marrow is not functioning fine. But if the bone marrow doesn't function fine, every cell in the RBC lineage would be less. I mean, your proerythroblast, early, intermediate, late, the nucleated RBCs, and finally the reticulocyte which is coming inside the blood, all of these will be less, right? And the RBC will also be less. Whereas if we talk about the second cause because of which RBC could be less inside the blood, that is the destruction of the RBC, matlab hemolysis. If the destruction of the RBC is happening, the signal is going to go to the bone marrow that the RBC count is going less. So what is going to happen to the retic count? The bone marrow will try to form more RBCs because bone marrow is not at any problem. So bone marrow will try to help the body. So it will form more RBCs, and because it is trying to form more RBCs, more number of cells you will be seeing in the blood in the form of reticulocytes, because the production of the RBC inside the bone marrow is getting more. So in hemolysis, you will never have reticulocytopenia. Instead, you could have reticulocytosis, right? Decreased haptoglobin, yes, it is a feature of hemolysis, intravascular hemolysis per se. Neutropenia, we are not concerned about neutropenia here. We are talking about hemolysis. So again, if reticulocytopenia is not the answer, all of the above cannot be the correct one. So the correct answer for this question will always be decreased hepatoglobin. Again, a simple straight question. Splenectomy will be useful in which of the following? Again, I'm sure that all of you must have done this question right. We have discussed this in the class that with hereditary spherocytosis, I told you that hereditary spherocytosis, the problem is the RBC becomes rigid, and that is why the spleen is not allowing these rigid RBCs to pass through it. So when the patient becomes a lot of dependency on blood transfusion, what we do, we take a decision by looking at the pros and cons, and we can go for elective splenectomy. So we have written this, elective splenectomy can be done for hereditary spherocytosis, and hereditary spherocytosis was given in the option that ITP, no use, PNH, no use, GCSPD, no use. Again, a straight question which comes from the notes. In sickle cell anemia, this is one of the most easiest question in this exam. Sickle cell anemia, we have discussed, you must have read it multiple places. And this is the first thing for sickle cell disease, the sickle cell anemia we do, that in sickle cell anemia, instead of hemoglobin A, which is made up of alpha 2 and beta 2 chains, HbS is seen. And in the HbA, in the beta chains, at 6th position, we have glutamate. But because of the missense point mutation happening at the 6th position of beta chains, the glutamate is gone. And what is coming now? Valine. So this is a missense mutation, point mutation, which is happening, and because of which the glutamate is going into valine at the 6th position of beta chains. These were the options given. So beta jata kaun hai? Glutamate. Ye ganda hai. So ye chala jata hai. And who is coming? Valine. I mean, we don't want it. I mean, we want glutamate because we want hemoglobin A. But in this, the mutation occurs and this happens. So the correct answer for this question is A, glutamate to valine on 6th position of beta chain. Then identify the cell in the image given below. I mean, I don't know how many times we have discussed this. This is one of the easiest questions which can come from WBC disorders. Owl-eye appearance cell. Straight away they have asked it, what is it? And the image also was same, and they gave the classical RS cell, no confusion in that. This is a Reed-Sternberg cell. Multiple times we have done in our classes that, there were two questions actually which came. One was a classical RS cell. We have discussed that this is an owl-eye appearance in the RS cell. And the second image which students have told me that there was another question in which they gave this particular image and they asked what is it, owl-eye inclusions are seen with. And I told you that this is actually all the inclusion bodies, the intracytoplasmic inclusion and intranuclear inclusion bodies of cytomegalovirus. And this is, we have written in the workbook, again a screenshot from there. So for this question, the answer is RS cell. And for the next question which came, that owl-eye inclusion bodies are seen with, that is your cytomegalovirus. Again, very straight questions which came in the exam. There's a 53-year-old male with back pain and lytic hip lesions. So they have seen, एक तो ये adult है, फिर lytic hip lesions है. On investigation, he was found to be having fatigue and pallor. So anemia दिखा रहा है. Calcium levels were found to be 12.8 grams. This is not grams, this is milligrams. 12.8 milligrams per deciliter. Plasma cells were more than 42% in bone marrow. Identify the condition associated, and they have given this image. We have discussed this image multiple times. This is a Mott cell. So as soon as you see this image, you understand they are talking about multiple myeloma. Even when I was teaching you multiple myeloma in the class, these are the exact, screenshots from the workbook, that for multiple myeloma we have discussed about these criteria, and I told you that in the criteria you have to see a plasma cells in the bone marrow which has to be more than 10%. Normally plasma cells are less, but if it is more than 10% in the blood bone marrow, we call it as one criteria for a multiple myeloma. M protein, the monoclonal protein, should always be present, and then we should have CRAB, the hypercalcemia and the renal failure, the anemias and the bony lytic lesions. So all those were given in the exam in the history of the patient. So again, and these four cells I've told you, the Mott cell, then your flame cell, and then the Russell cells and the Dutcher cells. So all we have discussed. So straight, I mean, this is an easy question. In every exam, they're asking some question in multiple myeloma, but this time they've asked the easiest of all the questions which they've asked even prior. The correct answer for this question is multiple myeloma D. Again, one more question came in from the multiple myeloma, and they asked that identify the plasma cell disorder seen in the image given below. Now, again, if you have studied multiple myeloma properly, the plasma cell disorders properly, I mean, there are multiple plasma cell disorders which we have talked about in the classes. Like we have discussed the MGUS, we have discussed Waldenström, we have discussed Smoldering. And see, So plasma cells getting so high, this is a very characteristic feature of multiple myeloma, right? More than 10% plasma cells. So again, from this, smoldering myeloma also have more than 10%, but that is not given in the options. So there is no confusion as to. HCL is not a plasma cell disorder, so it goes out of the context. And MGUS and Waldenstrom, they do not have that much of plasma cells. So the only answer left with this is multiple myeloma A. Then, which of the following factors is involved in extrinsic pathway? I mean, again, the easiest question which can come from the platelet and the coagulation disorder chapter, which we have done in the classes. No disease they have asked, but they have asked the straight question, this we have discussed multiple times. We have learnt it so many times. I hope each one of you remember the intrinsic and the extrinsic pathways. So they have asked that which of the coagulation factor will not be involved in the extrinsic pathway, or which will be involved in the intrinsic pathway. So, you know, in the intrinsic pathway, there are only 3 coagulation factors which are getting involved, which we have done. The 7, 3 and 4. So we have learned that 3 plus 4 is 7. Like that we have learned. So 3, 4, 7. These are the extrinsic ones. So let's see. Out of the given options, only 7 is given. So it becomes the answer. 8, 9, 11, all these are your intrinsic pathway ones. Okay? So again, a very straight question. Again, came from the workbook itself. A female took aspirin for headache. She developed some allergic reaction. This would be related to which of the following? Positive skin allergy test, associated with nasal polyp, increased IgE and tuberculin test. Now this is a question which came from the Samter's triad. So when we are talking about chronic bronchitis, in that, you know, we have discussed that this is a Samter's triad, which is there on the topic of respiratory system in the pathology workbook, where I've told you that ASA is like aspirin intolerance in this patient happens. This has happened. This patient will have nasal polyp, and the patient has a problem with the with asthma. So, you know, when we are talking about bronchial asthma in that respiratory system, I told you this. So again, a very straight question came a question from the Samter's triad. So this is associated with nasal polyp. Okay. Then ground glass opacities are seen with. Now ground glass opacities, the options were given only from pneumoconiosis. So when I was teaching you pneumoconiosis, we have discussed this again. The most common pneumoconiosis is silicosis, and in silicosis you see axial calcifications, and even on CT and X-ray you can see ground glass opacities. So again, a question directly came from the notebook. So this is your silicosis. There were 2 questions from pneumoconiosis which came this time. Like this is the second question from pneumoconiosis which came. A 48-year-old factory worker came with complaints of respiratory difficulties to the clinician. On evaluation, he was diagnosed with asbestosis. They specifically asked that what is the most specific association with asbestosis. And when we were discussing asbestosis in the class, these are our class notes. So in that we have discussed that, you know, the most common cancer associated with asbestosis would be a lung cancer, but most specific cancer associated with asbestosis will be mesothelioma, which is a malignant pleural tumor. So again, a very straight question which came. So the answer would be mesothelioma in this. A 67-year-old male suffered MI. On performing the biopsy, red and white patches were observed. What is the stain used to differentiate between these 2 patches? Now again, a very straight question. This is again a screenshot from the pathology workbook. We discussed that, you know, when we are checking about the MI and if the patient is dead and we are doing we are checking for the infarct, we have to take the cut section from the heart and we have to dip it in a beaker containing TPTC, triphenyl tetrazolium chloride. And we discussed that, you know, it will give us 2 areas. One is going to be red and white. One area which is red, white is red because TPTC in the presence of LDH. LDH is present inside the cardiac myocytes, LDH1. So if the LDH is there, then TPTC would give it red color. And if the LDH is absent, why would it be absent? If the myocardium is damaged. If the myocardium cells are damaged, the LDH will go out. And if there is no LDH inside the myocardium, there will be no red color. So white areas depicts infarct and red areas depicts normal areas. So which dye is helpful in differentiating between these 2? This is your TPTC. So again, a very straight question which came in the exam, TPTC. An elderly female presents with complaint of severe headache. She also complains of vision loss transiently. What is the probable cause? Now again, if you see the options, they are trying to take you to the vascular disorder, the different kinds of vasculitis. When we discuss this temporal arteritis or a giant cell arteritis in the class, this is what we have written. This is our class notes again. You can go and see on page number 196 that we have discussed that most feared symptom would be sudden blindness due to involvement of what? Ophthalmic artery, and the most common symptom is temporal headache. So elderly. Okay, we have discussed that giant cell arteritis generally happens in people who are more than 50 years of age. So elderly female, okay, having headache plus transient vision of loss. So obviously, if the causes could be many, but if they have mentioned the vasculitis over there, so out of the vasculitis given, Takayasu will be less than 50 years, and there would be no vision loss as such in that. Migraine will not lead to vision loss. Encephalitis again, it is not associated with vision loss transiently. So out of the given options, the best option would be temporal arteritis. Okay. Then a 73-year-old chronic smoker comes to the OPD with changes seen as the image below. Comment on the diagnosis with the findings seen. So when you see, they are saying chronic smoker, and you are this, obviously when somebody is smoking, there would be a problem with the blood flow, and you see a lot of things. Raynaud phenomenon can also be seen, but this is not Raynaud phenomenon, man. This is, a patient going towards the gangrene. So when we are talking about the Burgess disease in the chapter of vasculitis, again, we have discussed that it's called as Fmge obliterans, seen in smokers, and out of the given options, Burgess disease is IgA nephropathy. Okay, so spelling may difference there, but IgA nephropathy, why IgA nephropathy will have this? Giant cell arteritis will have, there is no association as such with smoking so much. Okay, and this is not the place where it would be, occurring. Raynaud phenomenon, yes, it could happen, but this is not the image of Raynaud phenomenon, right? So it is Burgess. Again, a question which directly came from the notes. Comment on the finding given in the image below. Now, this is, I would say, it is not that we have not studied it. We have studied it. Again, this is a question which came directly from the workbook, the last chapter of the workbook, the vascular disorders. And in that, we have discussed that, this is the image which I have shown you, and we have said that this is the hemangioma, capillary hemangioma. It is most common. It is seen in children, okay, and it is there on the skin. So again, ये आँख के ऊपर बेटा skin पे है, and they have given you these lymphangiomas and hemangiomas. So by the image, you understand that whether it is hemangioma or lymphangioma. So this is hemangioma, and more commonly, what is seen in kids, capillary hemangioma. So this is the answer again. 50-year-old lady presents with knee joint pain to the OPD. On evaluation for the differentials, needle-shaped crystals were found, but they were negative birefringence. So birefringe negative है बेटा. Comment on the diagnosis. So as soon as you are seeing knee joint का involvement है, ठीक है, needle-shaped crystals है, uric acid होगा, तो the point is that you are understanding that patient is trying to, the doctor is trying, the examiner is telling you that this is a question of gout. Needle-shaped, negative birefringence. So when we were discussing, the gout in our medicine classes, again a screenshot from the workbook, we've discussed that there would be needle-shaped crystals which we'll be seeing. Okay, so there will be needle-shaped crystal which we'll be seeing, but what we have discussed is that in gout, the refringence would be negative. You got confused regarding gout and pseudo-gout. In pseudo-gout, yes, the knee joint is involved. I understand that, but in pseudo-gout, the refringence will be positive. Here they are talking about negative birefringence, so the answer would be gout. Okay, again a question which directly came from the topics which we have discussed, and we have written all that. A 35-year-old lady presented with MTP joint involvement. On evaluation, uric acid crystal levels were found to be elevated. What is the drug used to treat this condition? Again, very straightforward question. Okay, when we were discussing the treatment of gout, we have discussed that the best treatment for gout will always be aripiprazole. Okay, एकदम straight है. You must have done this very frequently in pharmacology as well, and we have discussed in our classes as well. So by seeing all these questions, when we as faculties, when we see these kind of questions coming from in the exam, and you are telling us, so it gives us a sigh of relief that at least people who trusted, who studied, who gave everything for the exam, they must be able to correlate these questions from multiple places, and it gives you that kind of confidence in the exam that हाँ यार ये अपन ने पढ़ा था और अपना question आ गया. So that is what we want, right? So again, what is the drug used? Allopurinol. The best drug is allopurinol. Okay. Then one more question came on the same topic, and in which what students have told me that the difference between these two questions was, in one they were asked what is the drug used to treat, and the second question was that what is the drug you would use in patients suffering from gout so that the renal excretion of the uric acid increases. And this also we have done in the class, that if chronic gout is occurring and it is due to under excretion, the person is having high levels of uric acid, we have to start with probenecid, because probenecid is increasing the excretion. So again, a very direct question which came in your exam from the topic of gout. So again, 3 questions from gout. Okay, chaliye. A factory worker complains of gastric upset. He has eaten outside from last few days. He was not at home. After some days, some of his friends who also went to the same place to eat had same symptoms. Okay, which of the following can be responsible for the same? So, beta, कुछ viral infection है, and obviously gastric upset हो रहा है, तो we think about hepatitis, and option भी आप देखोगे तो hepatitis पूछ रहे हैं वो, and the hepatitis they gave, I've been told that they gave A, B, C, D, and when it is like a one person had and other person also had due to food, so that means we understand that there is some fecal-oral transmission which is occurring. Out of the 4 hepatitis given, what is the hepatitis which is fecal-oral? Now when we discussed the hepatobiliary system में hepatitis अपन ने पढ़ा था, so A and E they are fecal-oral, so E तो दिया नहीं था, E they have not given. What is it? Hepatitis A. But such easy question from hepatitis. I mean, they have not given any viral markers. They have not given any question on, B, C, all that combinations they have not given. They've asked a very simple question. I hope each one of you have marked correctly. Each one of you. This question was not a very expected question, but we discussed this in the class when we were doing the hepatobiliary system, the cirrhosis part when we discussed. Child-Pugh score includes which of the following? I hope you remember that for the Child-Pugh score, I gave you this mnemonic that it is telling you the severity of cirrhosis, and it includes all this. And the mnemonic was CR. And in the classes, I remember when I used to say this mnemonic, and you used to go up with me CR like that. So I hope it helped you in remembering this and in marking the answer correctly. The option which I got was, people told me that only one option was which had ascites in it. Rest no option had the ascites, and people knew that Child-Pugh score is associated with cirrhosis, and cirrhosis one complication is ascites, and even they were not remembering the entire CR thing, but because ascites was only given in one, so they were able to answer that. So I have made it like this. I mean, I took the ascites in 2 options, but you let me know what was the correct options if you remember. But according to the mnemonic CR, it is serum bilirubin, INR, ascites, esterixis, and albumin. So the correct answer is this. 18-year-old boy presented to OPD. He has a history of recurrent jaundice since childhood. बचपन से है, but now he's 18 years old. Lab diagnosis shows increased ALT, ASP, both the levels of, some people said that only increased ALT, AST was given, some said some high levels of this was given. So I don't know, you tell me in the comment section below what was it. Serum bilirubin was 5.1 milligrams per deciliter, and that out of this direct was only 0.6. So everything was indirect rest. So indirect unconjugated, and which condition may it lead to get this scenario. So when we discussed hereditary hyperbilirubinemia in our lectures, again a screenshot from your MIST workbooks. So when we discussed this, I told you this, we made this diagram, and we did it in one go, that there are 4 diseases in hereditary hyperbilirubinemia which we are reading, the Gilbert one, the Crigler-Najjar, the Rotter, and the Dubin-Johnson, and out of that 2 are unconjugated related, 2 are conjugated related. So unconjugated wali beta Gilbert ho gayi aur Crigler-Najjar ho gayi. Crigler-Najjar is more severe because the enzyme is not at all available. Okay? So if that's the scenario, this patient would be suffering more severely from jaundice, or itne time tak, because it is very severe and it can lead to death also, Crigler-Najjar. So obviously when you have to choose this way, so you have to choose the most common one, because the symptoms are not that severe. Gilbert is more common and the symptoms are not that severe because the enzyme is there but it's working in less capacity. So the correct answer for this question is Gilbert syndrome. Child present with the following presentation, comment on the diagnosis. Now, very straight question. I mean, they have given you the snowflake cataract, they have given you the Wilson's, the K.S. ring, and when we were discussing the metabolic diseases of liver in the chapter of hepatobiliary system, I hope you remember that we have made the table Wilson's disease and hemochromatosis, and there we have discussed these diseases with every organ involved, and in the eye I told you that there would be a K.S. ring which would be there in the Wilson's disease. So रिंग देखते ही बेटा स्ट्रेट हो जाता है. कॉपर metabolism is a problem. The copper excretion is an issue, and because of excess copper, the Wilson's disease is happening. So copper deposition हो जाता है. So this is the answer. Is very straight Wilson's. Now this again has the question which came from the iron toxicity. A mother brought the child to the ER. She gave a history. Her child drank a bottle of iron syrup. So iron toxicity हो रही है. What should be used for the management of this? So we've discussed in hemochromatosis. I told you that for any kind of iron toxicity, we have to give iron chelators, and this is desferoxamine. So you must have seen this in other subjects as well, in pharmacology, in biochemistry maybe, in forensic also. So, but then we also discussed this in the class in the chapter of hemochromatosis. In the topic of hemochromatosis, liver chapter. Straight question. You must have been able to solve these questions. Till now, there were not many questions where there was a confusion. If you had the proper attention while reading this, they were easy. This was one question. People told that this was one of very few questions in the whole exam which had a long history. So this is a question from glomerulonephritis. Let's see the question. A 7-year-old boy child present with hypoalbuminemia, edema, hyperlipidemia, and proteinuria. Okay, the edema is in the periorbital region initially and eventually spreads to the rest of the body. The patient is given steroid therapy and the disease goes away. So it is very highly responsive to steroid. Renal biopsy on light microscopy was unremarkable. And many students told me, sir, as soon as we read this, we knew what is the answer. But on electron microscopy, effacement of food process of podocytes was still. There cannot be any question which can be more answer giving than this. There's such a long question, but they have given everything in this. What is the diagnosis associated with the same? बच्चा है बेटा, proteinuria हो रहा है, nephrotic syndrome का question है, effacement of food process of podocytes on electron microscopy. Straight away, when we discussed this in the class, again, this is the screenshot from the workbook, pathology workbook. We have discussed that minimal change disease, which is also called as lipoid necrosis, most common cause of nephrotic syndrome in a child. And we discussed that, initially the edema would be in the periorbital region, and with time it will subside, it will go down. And we have discussed this very cleanly. We have written that light microscopy, no finding whatsoever. That is why it is called as minimal change disease. But on electron microscopy, when you go, so you'll find the effacement of food process of podocytes. So again, a very simple question which came in the exam. I hope and I pray all of you have done it correctly. So minimal change disease. A 24-year-old patient presented with hematuria and edema. He has a history of throat infection 10 days back. Lab investigation showed hypocomplementemia. Comment on the diagnosis. Again, if you see the options, you understand they're asking from the renal system. They have given all the kinds of glomerulonephritis to us. And when we discussed PSGN in the class, we said that it's happening in the child. Then the etiology is group A beta hemolytic streptococci. And I've told you multiple times that always and always will be a history of throat infection. And then we discussed this also because this will also cause hematuria. It's a nephritic syndrome. And IgA nephropathy, which is the most common glomerulonephritis, also causes hematuria. So how to differentiate? Just check the complement level. In PSGN, the complement levels will be low, hypocomplementemia. So they have given everything again, and it was very easy to differentiate between IgA and PSGN. So IgA, there would never be a history of any kind of infection. So in PSGN, it has. So the correct answer is A again. Then 34th question. A patient presented with hematuria and hemoptysis. Investigation also revealed anti-GBM antibody. People said, sir, we didn't read anything. This came and we knew what was the answer. Comment on the diagnosis. Now, I have discussed this. The anti-GBM antibodies, they are seen with good pasture syndrome. And we have discussed it at two places. One, when I was teaching you vasculitis, and we discussed about all the antibodies seen in the vasculitis. So I told you that anti-GBM antibody, they are seen with good pasture syndrome. And when we were talking about RPGN in the chapter of renal system, I told you that RPGN can be of three types, type 1, type 2, and type 3. Type 1 RPGN can be due to good pasture syndrome. And I gave you a mnemonic over there, 1, 2, 3, 4, 5. And in 5th point, we discussed this, that good pasture syndrome involves kidney and lungs both. Okay, so again a straight question. I hope all of you were able to answer this. This is good pasture syndrome. Tom Horsfall protein is seen in. Now they are asking in which caste it will be seen. So obviously Tom Horsfall protein, we have discussed when I was teaching you the chronic kidney disease, we discussed that how much of protein loss happens every day normally inside. And we discussed that when we have proteinuria could be of two types depending upon nephritic, nephrotic, depending upon how much we are losing, like more than 3.5 grams per day, so nephrotic, less than 3.5 grams per day, nephritic. But we also said that normally we are losing approximately 150 milligrams per day. Not nephrotic, nephritic is grams, है ना? ये 150 milligrams per day, and out of this 150 milligrams, less than 30 will be albumin, and approximately 120 will be Tom phosphol. So Tom phosphol proteins, we are losing every day normally in our urine. And I told you that in a normal condition, in a normal person, when I was teaching you this urinary cast, this urinary examination, in the cast, I told you that, any dehydrated person, any normal person who is dehydrated, or in a pregnant female, you can see these hyaline casts. Okay, so the option which we have is a hyaline cast here. Somebody said it's a urinary cast was also given, so it's the same thing. It's not a problem. So hyaline cast. This was the answer for this. A 60-year-old patient suffering from Cushing syndrome, what is the most common cause? Now, this was a very, I was expecting some other things also in this question, but to whoever student I talked with, they said, sir, it was only a two-line question. And they said that, a female was suffering from Cushing syndrome. What is the probable cause? Now, the point is that the other options were adrenal adenoma, suprarenal carcinoma, ectopic CRH secretion. So CRH, if they've given ectopic CRH and ACTH, so out of these ACTH becomes the better option because ACTH is directly working on it. The point is that why we are not choosing adrenal adenoma or suprarenal carcinoma for this question, why the answer is ectopic ACTH, because like these adenomas and carcinomas, they're not that common. So out of the option given and how the question has been asked, I would say the ectopic ACTH secretion is the right answer instead of choosing any cancer for this. If there is any other addition to this question in the options or in the question you feel so, please let me know. Okay, we have discussed this when we were discussing Cushing syndrome in the chapter of endocrinology. We discussed this, again, this is a screenshot from the endocrine workbook, and we have discussed that, the ACTH would be high in the patients who are suffering from Cushing syndrome because cortisol can rise due to extraadrenal pathology and some iatrogenic causes like the steroid intake. So if the steroid is the reason, if let's say that is given, then the ACTH would be low, then it cannot be ACTH. But if nothing is given, then, we can think about ectopic ACTH secretion leading to Cushing syndrome. Again, a question came from the workbook. If there is more history, please let me know. Another question, most common cause of death and decay. Now, see guys, in this question also, some of you have made a mistake. Some of you have marked dehydration and some of you have marked sepsis. The thing is that dehydration is definitely going to be there, but death more commonly due to dehydration doesn't happen because the first thing we are doing for the decay patient is, I understand, we give IV fluids straight away, but it doesn't kill the patient that often as the cerebral edema. Sepsis also could occur, but it will not kill the patient as commonly as cerebral edema. So the correct answer for this question, after consulting the textbook, it is going to be cerebral edema. Okay, we have discussed this. Lady presented with headache, palpitations and sweating. She also is hypertensive and adrenal mass is also noted. Comment on the diagnosis. Now, once you see the option, you understand that they are talking from the endocrine, and this is a triad which they have given, and this triad we have seen, when we are doing pheochromocytoma. I mean, we have discussed this, that there is a triad in the pheochromocytoma, which I said that this becomes HSP, but this is not henoxolin purpura, this is headache, sweating and palpitations. Okay. So again, this is a straight question which have come from our notes, and it is pheochromocytoma. A 36-year-old male suffering from finger enlargement in foot, and students even mentioned that, sir, in the bracket they have mentioned acromegaly. What should be the treatment for this patient? Now, when we are discussing this acromegaly, I told you that acromegaly is due to excess growth hormone, and growth hormone can have a central action and peripheral actions. So we can give growth hormone inhibitors like pegvisomant, and we can give octreotide, which is, somatostatin. The growth hormone is being secreted by the somatotropes. So if you block the somatotropes, no growth hormone will be secreted. And if you block the growth hormone secretion altogether, so you are controlling not only the central actions, but also the peripheral actions. So the better choice would be octreotide in this. Okay, bromocriptine, cabergoline, these are not related to here. They are related to the pituitary problems. And octreotide and pegvisomant, they both are given in pheochromocytoma. But as we said, the acromegaly. But as we said, that octreotide is a better choice because it controls all the peripheral actions as well. Damage to these cells. Now, this is one question which we have not discussed as such in the classes. But what I have come to know is that these were the options given, and because they have mentioned that damage to these cells, so if we talk about the Cushing syndrome, it is not due to damage as such. Acromegaly, it is also not due to damage. In that, this is excess. Okay, so these two are ruled out. Then, if this image was there, this is the image of islet cells of pancreas. This is histology of pancreas, and in that, these are the islet cells. So if the islet cells are being destroyed, obviously the insulin will not be produced, and if insulin is not produced, obviously diabetes mellitus is the answer. So I discussed with many students, and they said, sir, there was nothing else we could find out. So majority of you have marked diabetes mellitus already in this. Antibody present in highest concentration in the blood. Now, antibody which is present in the highest concentration in the chapter of immunity, we have discussed that five types of antibody we are having, and in this sequence their concentration is. So the maximum concentration is G. And while telling you in the classes also, I said that M is the biggest one because it is pentameric, but do not make it as the highest number. We've discussed this. I've said the exact line. So I hope you remember that line, and the correct answer for this question was IgG. Okay, so these were a few questions which I was able to gather. If you remember any other question which came in the exam which I have missed, please comment on the comment section below. We are pretty sure by seeing the questions which came in the exam that you people must have done right. After the examination, obviously there is a doubt which comes into our mind that whether we have corrected this. Some of you would even forget that whether I had marked this answer or not. You would find, no, I may have marked that, I may have marked that, but you're not sure. So beta, unnecessary overthinking nahi karni hai. Do not overthink. You did what you could in the last 5-6 months. You tried to give your all. You sat in the exam, you gave the exam. Just this is the time which you are craving for actually, that you are free till the results are out. We are pretty sure by seeing the exam that the results should be good. We know you people have given everything. When the results will be out, you'll be proud of yourself, and everyone else would be proud of you also. Okay? So at this time, talk to your parents, talk to your loved ones, have some time with them, because very soon when the results will be out, you'll be starting with your internship, you'll be starting again with your PG preparations, with your jobs and all that stuff. This is the time when you are not having that responsibility as such. So make sure that you are utilizing this time as to what has to be done, because they waited for you for many years. Your parents are waiting for you for many years to sit with them, to enjoy with them. I know most of you must be doing it, but do not waste your time in anything else. Do not waste your time in thinking a lot what's going to happen, because whatever had to happen, it happened. It's already. You've marked it, you've submitted it. And with the blessings, with your hard work, with all what you have done in 5-6 months, results are going to be good. Okay? From the entire MIST family, we wish you good luck for your results. Hoping to see you soon on the other side. Take care. Bye-bye. Thank you very much. And yeah, one more thing I want to add here, that I really want to thank all the students who have helped me in making this recall. Thank you very much that you gave your precious time and you came to us and you gave us the recall. If there is any discrepancies, guys, if you find any question up and down, please make sure that you are commenting in the comment section below. Thank you very much. God bless you all. Take care.